meeting after our conference that was held on 23rd to 25th of September. And I want to announce that we already have the CME accreditation approved by 19.5 CME accreditation by DHA. And we will start sending our certificate according to the email those they register in the conference by next week, inshallah. This is first. Second, I would like to congratulate our dear old friends in India, doctors, by their Diwali. And also we'll have now today our meeting, and I wish to enjoy the meeting and the discussions by our pioneer speaker today that we are having. Our first speaker is my dear friend, Dr. Ahmad Al-Kashab, and he is going to give his talk now. Dr. Ahmad, the mic with you, please.
Thanks a lot, Dr. Muhammad. It is always my pleasure to be with you and to join the MEOM activities and meetings. Today, my talk would be directly about some case presentations, and the most common of these are the diabetic patients, and we are facing these patients always in our clinic, and that's why the first case is a 56 years old female patient. She is hypertensive and diabetic for over 18 years. When she presented to me, the hemoglobin A1C was 8.1, not goodly controlled, but not bad as well. She had severe NPDR and diffuse diabetic macular edema with some minimal nuclear sclerosis. But the vision is 2150 in the right eye and 2200 in the left eye. This is the OCT image of both the right and the left eye on presentation. So in the right eye, there is, as you can see, some intraretinal and subretinal fluid. The central thickness is over 530 microns, while in the left eye, the central thickness is about 480 microns, and there is no subretinal fluid. So this is at presentation. So as usual, I explained to the patient that this needs to be tackled, and for diffuse central involving macular edema, the treatment of choice is anti-VEGF. And in such cases, I would definitely prefer to use Eylea because of the better drying effect in my hands. So we started at that point. The vision was 2200. This is after the first injection, we've seen that there is marked reduction of the subretinal fluid and the intraretinal fluid, but still not fully there. Second Eylea injection, the OCT image is better, but we need to continue, and this is very important. This is after the second. This is the OCT angiography after the second injection, and the blood supply is not markedly affected, and there is some capillary dropout, but mainly outside of the foveal avascular zone, so there is no ischemic changes or ischemic maculopathy. And this is after the patient, after the second injection, actually traveled, and she disappeared for 1 month, and she came back with the edema, recurred again, but no subretinal fluid at that time, and the central subfield thickness is 513 micron. Again, we started the fourth injection. The vision actually improved to 20/50, and the patient is more focused on the treatment. And this is after the fourth injection. The OCT angiography is still very good, and the edema is almost reduced, and I gave her the fifth injection just early this month. I didn't see her yet to have the image in the right eye, but let's have a look on the left eye. So this is the left eye at presentation. The vision was 21/50, and with this marked edema, intraretinal, and some cysts. the central thickness 444, and this is after this is the second injection. Definitely the edema is much better. Central thickness is 340, so more than 100 micron of reduction of the central subfield thickness. Then again, the third injection, the edema is decreasing even more. The fourth injection, despite that she disappeared, the same patient, but she disappeared, the vision and the edema continued to improve for the left eye. And now the central thickness is 235 micron. This is the OCT angiography of the left eye. Despite some areas of capillary non-perfusion, the vision and the condition improved tremendously. The vision improved to 20/25, and this is at the injection of the fifth injection. The edema is totally gone. The vision is much better, and actually the ETDRS scoring of this patient is much better now. So not only the reduction of the edema, but as well the reduction of the severity of the diabetic retinopathy severity scale. So in this case, we are tackling 2 at 1, not just tackling the edema, we are tackling the edema and the severity of the diabetic retinopathy. My question, and this is the OCT angiography again. So my question, what to do next? So should we continue on monthly Eylea, or start to do treat and extend, or some fixed regimen every 2 months according to the label, or to switch to a steroid implant? If I would move on, I would definitely not to continue on monthly injection, except for the right eye until stability, and then I'll start treat and extend. And that's my regimen. Although fixed regimen gives a very good response, but I would definitely not switch to steroid implant as long as the patient is well covered and well controlled with Eylea. What do you think, Dr. Ayman?
I totally agree with you. I do the same in my diabetic patients. I start the anti-VEGF until they are dry completely. Then I move to treat and extend in these cases. Definitely, I totally agree with you.
Okay, Dr. Ayman.
My approach would also be the same. Yes, my approach would also be the same.
Okay, but there is a question, Dr. Ahmad and Dr. Ayman, Dr. Raj. As you know, for Eylea, we are usually, the label should give 5 loading dose. What is, are you following this one, Dr. Ayman, Dr. Raj, and Ahmad, even if it is improving? For example, if the patient improve after the 3rd injection, are you going to go for treat and extend, or you are going to continue the 5 loading dose?
And I know that the company says recommendation is 5 injections to start with, monthly injections, but no, I don't do this. Although all the studies have shown that the more injection you give, the better drying. But no, I give Eylea until the patient is totally dry. At least I give them 3. After the 3rd, if the patient is dry, I move to treat and extend. No, I don't continue on monthly.
Okay, Ahmad, what is your protocol?
Despite that, I agree totally with Dr. Ayman, as the studies is the more the injection, the better the drying. But still, if after the 3rd injection, the retina is totally dry, I'll start to treat and extend. I will not keep on injecting monthly, despite of the label.
Rituraj, you have any different or the same?
I go for 5 injections. Most of my patients which I handle are the switch patients. So they have been earlier treated before, and they are like having persistent macular edemas. So for them, I require to go ahead for the full dose of 5 injections. And then if they become dry after 5 injections, then definitely I go for treatment.
Can I ask you, Dr. Rituraj, if, sorry, Ahmad, you want to?
Definitely.
Okay, Rituraj, you said that you are most of your patients that are switch, you mean from Lucentis or Avastin to Eylea. So when you are doing switch, you start also to give 5 loading dose, or you give only a certain, 1, 2, 3 till dry? You start
No,
him as a new patient or what?
I start him as a new patient.
What do you think,
Consider
Ahmad?
it
How
as,
do you do?
The problem is the aim is to dry the retina and to maintain the retina to be dry. So if we reach to dryness of the retina total, I'm not talking about persistent. If there is some persistence, even after the 5th, I will continue on monthly. So for example, for the right eye, if there is still edema, I will give the 5th and I will give the 6th after 1 month. I will not move on to fixed. I will not move on to extend. So the aim is to dry the retina and to preserve this dryness and this best visual acuity. So if you reach this after 3rd injection, I think it is quite enough. And then you'll start. You never stop. So the aim of what is called PRN, I do not agree totally with. Against. I'm totally against. I think it is. We can label it. I think I heard it in one meeting. Progressive retinal negligence. So we are neglecting the patient until he relapses again, and then we can start again. So never do that. So either to have fixed regimen, if you agree with this, or treat and extend, and the extension would be on 2 weekly basis.
Ahmad, maybe I think my question was a little bit different. Dr. Ayman, if you understand, if you switch from another anti-VEGF to Eylea, are you going to start the patient as he is, you are going to give him a 5 loading dose, or you will start him as a continuation, and whenever the dry is happened, then you will stop?
No. When I'm switching my patients, for example, if he's on Avastin, for example, he's not responding, and I gave him, there is a difference between non-responders and partially responders.
No, if we are saying
if we say partially responders, for example, and I give him Eylea and he is completely dry, I treat and extend. I go to treat and extend from this point. Why? Because of the financial burden for the patient or for the institute. Number 2, with every injection, you have the risk, although it's very, very low, you have the risk of infection, inflammation, etc. Why to do this if the retina is completely dry? Now, if the patient is non-responder at all, I start him as a new patient. I give him the 3 injections, and then I look until the retina is completely dry. Then I'll treat and extend. This is what I do.
Okay, can I add only one question before we move, Ahmad?
Yes,
Dr. Rituraj.
Yeah, basically, it all depends upon which injection was used before, and how much time does that injection stay in the vitreous cavity, and how much amount the VEGF suppression is. For example, if you are using the injection Eylea, then as we know that the half-life is almost 71 days for it. And I basically consider that if the patient had an injection 6 weeks before 6 weeks, then that means the effect of VEGF suppression is not there, and I treat them as a patient of recurrent edema. If the patient basically has the injection almost within 6 weeks, that like 4 weeks, and still there is a macular edema, in that case, I think that in the presence of an anti-VEGF agent, still there is a macular edema. That means that the patient is not responding to that specific drug, or there is some coexisting pathology which I need to find out. So I go for further investigations and then decide about the treatment. Probably this Ahmad, would be, I would discuss in my cases, it would be better.
Maybe I need to highlight about this point because I think we are not, I completely agree. Okay, Dr. Ahmad.
Yeah, I would not agree totally with you, Dr. Rituraj. And I thought I was answering the question, Mohammed. So considering the patient as new patient, he's not new. He switched from one drug which was not effective or less effective. So even if there was some response, but you did not reach to the optimum drying effect that you wanted or the optimum visual acuity that you wanted, and then you switch to another type of anti-VEGF, which is more potent like the Eylea. So I think you continue until drying. So the number is not fixed. If you reach drying after 3 injections, well and good, but I would not stop after just 1. So if this is your question,
yeah,
I would
because
not continue.
that's my, it will be my, to highlight this point. You reach to my point. If suppose you switch and then you give him only one injection of Eylea, for example, after Avastin, and the macula is dry, then you will stop or you will continue at least 3. This one.
No, I would continue at least 3. Because he has been there and they had edema for a long time and it was not responding. So not on the first drying effect, I would stop or I will extend. I will keep on injecting on monthly, maybe second and third, and then I would treat and extend.
Dr. Ayman, you have anything different? Oh, sorry.
I do the same. I said if the patient is not is an non-responder, I would do the same. I will start with 3 injections, 4 until the retina is dry, then I extend. But
no, but my question is,
if the patient is partially responding, for example, if the patient has been responding, but the retina is not totally dry, then I gave Eylea and then it dried completely, I extend. Of course, I extend. I consider it's an anti-VEGF.
Okay, Doctor, I don't know, Ahmad, if there is something I can wait and discuss. There is one question more, or we continue and then we ask.
Let's continue.
And then I will keep this question to the end. Okay. Go, Ahmad.
So this would go with the VIVID and VISTA study. The early intensive treatment with aflibercept delivers continuous vision gains through year 1. And we all know and aware about these studies. And improvement is about 10.7 letters in the VIVID and 12.5 letters in the VISTA. An average patient across both studies gained more than 9 letters, about 2 lines of vision, after 5 initial monthly doses. At the week 52 primary endpoint was 65% and 58% of patients across both studies receiving aflibercept gained more than 10 letters from baseline. Again, in protocol T, significant vision gain seen from the first injection continued to rise throughout the early intensive initiation phase to reach 18.9 letters in the subgroup of 20/50 or worse vision. And in real life studies like the Apollon, meaningful vision gains were achieved in a real world setting with intensive aflibercept treatment in the first year. So we reach about 8.4 letters of improvement, which is mimicking the VIVID and VISTA. The Moorfields study with early intensive treatment in the first year, aflibercept achieved randomized clinical trial-like vision gains in the real world. At year 1, 7.1 letter of improvement. At year 2, this is only according to the injection, 7 injections. And at year 2, only 2.9 injections. At year 3, 2.6 injections. And the overall 3 years injections were 12.6. And letter gain from baseline is more than reaching to 69 letters. And in the patients, this in the subgroup of patients worse than 20/40, and 78 letters in patients of 20/40 or better. 89% of patients in the 3-year analysis received 5 initially monthly doses, as we agreed upon. And over half, 58% of the patients in the cohort had baseline visual acuity of less than 70 ETDRS letters. This is a point that we need to highlight, and we need to stress on the continuation of the treatment. So, because there is a drop in vision at year 2, suggests patient may have been underdosed 2.9 injections. Vision was maintained with 2.6 injections in year 3. So whenever we are reaching to the maximum improvement in visual acuity, I would agree with the study. If it is 5 loading doses, or you reach there after 3 injections, but you need to reach to the maximum improvement and then maintain it and maintain the patient under treatment and under observation. So the patient should not just skip out of the treatment and out of the guidance of his physician and doctor. With early intensive treatment in the first year, aflibercept can achieve randomized clinical trial-like vision gains in the real world, comparing VIVID, VISTA, VIVID East, and Protocol T. There is around 10.7 to 13.3 letters of improvement, as in Protocol T, while in Moorfields, Apollon, and we have about 9.9 letters and till 8.4 letters. So real life study providing the strict treatment regimen for those patients can give us similar results as the VIVID and VISTA and Protocol T. And only limited visual acuity gains resulted when early intensive treatment is not applied. So we have, if we lose the patient in between the treatment interval and skipping the injection to reach to drying effect, we have lesser improvement in visual acuity, reaching 4.3 and 4.8 letters only. If you may allow me, Mohammed, I will pass through the very fast through this case. I find that as a very interesting case.
Okay, if you can go fast, Ahmed, already we have 20
so
minutes.
This is a 61-year-old female patient, hypertensive, had glaucoma for 6 years on Zalatan Kusat, high myopic. She had cataract surgery done 6 years ago in another hospital. The visual acuity at presentation 2100 and 2025. Actually, this is a patient of mine for a long time. She was following up with me, but the vision was usually 2025 in the right eye and 2025 in the left eye. Quiet pseudophakia, tessellated myopic fundus, and tilted disc. This is at presentation. She had foveal schisis and what is suspecting as myopic CNV. I'm sorry, I lost the OCT angiography, or the nurse, she did not put it for me, so that I missed it here. But anyway, it showed very subtle CNVM. So I explained to her that we will need injections. She disappeared and she traveled actually out of the country, and she had some anti-VEGF treatment in another hospital out of the country. And she came back to me almost 4 months back with the same picture and with the same, with even dropped vision. So the vision dropped from 2100 to 2200, and the significant foveal schisis and irregularity of the retinal layers. This is at presentation at start of the treatment. The central subfield thickness is 459, and I switched to Eylea, and this is after the first injection, then second injection on monthly routine injection. No marked improvement, still a lot of foveal schisis and edema. And this is after the third injection, very subtle improvement. I would not say that this is significant or something like this. This is after the fourth injection. And still the edema and the foveal schisis is still there. I know the injection is not the treatment of choice for foveal schisis, but I'm giving it for the myopic CNV, and hopefully this would treat the foveal schisis. So at this stage, what to do next? We should switch to another anti-VEGF. She's already on Lucentis initially. She did not improve. Actually, the vision dropped. Or continue treating monthly, or some fixed regimen, or switch maybe to steroid implant. What do you think, Dr. Rituraj or Dr. Mohammed?
I would switch to another.
We have 1 minute only for that. Okay. Rituraj?
I would switch to another anti-VEGF.
Which is? It was
on ranibizumab, right?
Already she was on ranibizumab, then she was on Eylea. Now, so where you will go?
Yeah, in that case, the brolucizumab which is coming, I would try to go for it.
Okay. Maybe I have a different view of point of view.
Okay.
We all know that myopic CNV is the most easy to treat.
Yes.
And it's the best response.
I agree totally.
Myopic CNV. So whenever you have multiple injections, in this case, and not responding, the CNV is not responsible for the problem. What's responsible for the problem is the macular schisis. In this case, I would go for macular buckling. I would go and buckle the macula and then I'll take it from there.
Okay, I agree with you totally. This is very good understanding of the situation, but the patient did not, I'm not doing actually macular buckling, and I was hesitant to do surgery for her, and she was not accepting. Always, whenever the surgeon is not pro, the patient would not be pro. But anyway, let's continue. So I explained to her and I told her, let's continue and see. So this is after the 4th injection. I see some improvement. I decreased the interval a little bit by 1 week. And you can see that there is starting improvement of the 5th injection. The central subfield thickness is 400 micron. Now, same. Now this is 312 microns. And this is the OCT angiography. Sorry, it is late, but there is one here. And this is after the 6th injection. It is totally dry. It's amazing. So for me, it looks great. And the vision improved now to 20/25. And I maintain her now, started to maintain her on extension. So instead of 4 weeks, I switched to 6 weeks on the 6th injection. And I would hope that I would switch her again to every 2 months. So do not abandon the wagon too early. Sometimes very late response is still there and still be possible. This is not a typical case, and that's why I was very triggered to present it. Thanks a lot.
Thank you very much, Ahmad. Thanks a lot. Already we exceed the time, so we can go directly to Dr. Rituraj. Yes. Maybe at the end, if you have, then we can discuss the case again, Ahmad.
Yeah.
Okay.
All right. At the outset, I would like to thank Dr. Amri and the Bio team for giving me a chance to present in this forum. My topic today is titled Unmasking. Well, speaking about unmasking in this COVID era is a bit surprising, but unmasking also means to bring about clarity. So what I intend to do in this talk is to bring about certain clarity regarding the phenomena of switching the anti-VEGF agents and diabetic macular edema. So the case presentation would go in this pattern. Coming to case 1, it was a 60-year-old female, uncontrolled diabetic, no other comorbidities. She was a known case of diabetic macular edema. She had received 3 injections of Eylea in each eye before and was labeled as a poor responder and was advised elsewhere to switch over to the drug. The recent injection received was 12 weeks back. So this was the clinical scenario. The vision was 0.1 and 0.4. Pressures were normal. Entry segment was grade 2 nuclear sclerosis. Both eyes showed presence of hemorrhages in all the 4 quadrants, some cotton wool spots, macular edema, and there was some amount of hard exudates as well at the macula. The corresponding OCT in the right eye showed central retinal thickness as 383 microns, and that in the left eye showed 280 microns. Since there was presence of cotton wool spots, presence of hemorrhages in all the 4 quadrants, and since there was an initial advice to switch, I thought it would be prudent to go ahead and investigate further. So I performed a fluorescein angiography. And I noted that there were presence of capillary non-perfusion areas in all the 4 quadrants in the right eye and also in the left eye, in addition to there being an NVE nasal to that of the disc. Due to the presence of ischemia around, I went ahead with pan-retinal photocoagulation for both eyes, and I persisted with the drug Eylea and did not change it. I advised patient to undergo 5 injections of Eylea in each eye. Starting vision was 0.1 and central retinal thickness was 383 microns in the right eye, whereas starting vision was 0.4 and the central retinal thickness was 280 microns. The retina started to improve after each injections of Eylea, and this was the situation after the 5th injection, where the vision improved to 0.2 and left eye the vision improved to 0.6 with corresponding reduction in the central retinal thickness. The patient was asked to monitor the vision, and she visited to me 12 weeks post-injection, and the drying effect on the macula was still maintained the vision still in the right eye was 0.2, left eye 0.6. And correspondingly, the vision, the central retinal thickness was 244 in the right eye and 240 in the left eye. So when we analyze this case, we see that there is an improvement of vision in the right eye to 0.2 and that in the left eye from 0.4 to 0.6. There was a coexisting ischemia which was looked out for before the decision regarding the switch of the drug. And I feel due to the presence of ischemia around, that was one of the reasons why the Eylea basically was not responding well. Post 5 injection of Eylea, the therapeutic effect was well maintained for 12 weeks, and there was improvement in vision and central retinal thickness in both eyes post Eylea injection. Now, just to peep into the literature, the evidence-based medicine has taught us through multiple studies, and it is the protocol T and Vivid Vista who speak about aflibercept. The protocol T, as all of us know, speaks that aflibercept was better than ranibizumab and bevacizumab in 1 year with patients' vision less than 20/40. Whereas Vivid Vista studies spoke about aflibercept being better than macular photocoagulation in diabetic macular edema. Aflibercept, as all of us know, has a strong VEGF binding capacity, blocks all the VEGF receptors, and has a long duration of action. This slide is specifically to highlight the long duration of action of VEGF suppression. The VEGF suppression achieved by Eylea is somewhere around 71 plus or minus 18 days. When it is compared head-to-head along with other anti-VEGFs, it is seen that the VEGF suppression time for Eylea is almost 71 days as compared to ranibizumab being 36 days and bevacizumab being 49 days, and even brolucizumab estimated time being 52 days. So we have a drug which remains in the eye for a longer duration of time. We all of us know that Eylea is basically approved by the Retina guidelines, and as well as it echoes the findings of the protocol T, where it is the drug of choice in baseline vision acuity less than 20/40, as it shows superiority over bevacizumab over 2 years and ranibizumab in the first year of treatment. Even in patients with limited visual response, continued visual gain was noted with aflibercept, which led to gains of more than 6 letters even at week 104. So applying this knowledge to our case, basically what we think is that the DME, if it is not responding, then it is necessary to rule out ischemia before switching the drug. In case the ischemia is noted, treat it and persist with the drug rather than abandoning the drug, since improvement with Eylea noted up to 104 weeks. Eylea scores over other anti-VEGF in terms of efficacy, has a longer half-life with a consistent VEGF phase suppression over almost 71 days. And in this COVID era, we require a drug which has a good therapeutic efficacy and has a long duration of action, so that there are less number of visits. I will come to case 2. We'll have the discussion about case 1 and case 2 in the question and answer session. So I'll present the case 2 right away. It was a 55-year-old male, diabetic, uncontrolled, had come for a routine eye checkup, was a diagnosed case of proliferative diabetic retinopathy. This was the clinical photograph. Vision was 0.8, 0.7, intraocular pressure is normal, anterior segment unremarkable. There was presence of proliferative diabetic retinopathy, presence of NVEs in both eyes. We are able to see the NVEs very clearly here. The patient was advised to undergo both eyes PRP three sittings. After undergoing the pan-retinal photocoagulation, he traveled outside the country. He visited to me 3 months post PRP with complaints of blurred vision in the left eye. Vision in the right eye was 0.8, pressures were normal, anterior segment normal, and laser PDR was there in the right eye, whereas left eye showed reduction in the vision, was 0.5, and on the fundus, it was laser PDR with diabetic macular edema with the corresponding OCT being there. I advised this patient to undergo 6 injections of ranibizumab in the left eye. After 4 injections of ranibizumab, I noted that there was no improvement in the vision. And then central retinal thickness had just reduced from 416 to 361 microns. And I noted that there was still presence of intraretinal fluid and as well as subretinal fluid there in the left eye. So I thought that probably I might be dealing with a case of suboptimal response here, since there was no gain in vision. Let's analyze the OCT. I start biomarkers which might be probably indicating that there is some inflammation. I noticed that there is a subretinal fluid, but there was no reflective spots or hard exudates or drill or any retinal cysts as such. Patient did not want to take the risk of cataract and glaucoma, so I decided to perform a fluorescein angiography just to rule out whether there is an associated ischemia or not. Both eyes showed lasered stabilized diabetic retinopathy. Since there was no ischemia around and the patient was not responding to the prior anti-VEGF, I decided to switch the drug and advise 6 injections of Eylea for the left eye. Post 3 injections, I noticed that there is reduction of the central retinal thickness, the subretinal fluid also disappeared, vision improved, and I achieved a vision of for the left eye with central retinal thickness being microns. So this is the pre-switch OCT and the post-switch OCT. Here you can clearly see the improvement. Well, when we analyze the case, we see a diabetic patient, a laser stabilized PDR, which was confirmed on FA, suboptimal response to ranibizumab. The patient was shifted to aflibercept. There was an improvement in vision and reduction in the OCT central retinal thickness. Now, just peeping into the literature, what literature specifically tells us, it is the protocol I and protocol T, which speak about the persistent macular edemas, which are not responding specifically to anti-VEGFs. So these are categorized as suboptimal response to anti-VEGFs in diabetic macular edema. Amongst 40% of all total DAV cases have persistent macular edema, according to one of the study, and 32% suffer from visual loss. There is as such no univocal definition for response of treatment, but there are no improvement of vision, if the BCVA change is less than 5 letters or CRT change is less than 10%, then they are categorized as per the DRCR net as patients having no improvement. Well, the reasons can be multifactorial, involving upregulation of VEGF from local macrophages or altered expression of surface receptors and humoral responses. So when we just look into the literature and look into the protocol I and protocol T, they do speak about cases with persistent DME. Protocol I specifically speaks that the cases of persistent DME with ranibizumab keeps on reducing over a period of time till week 24. And it came to a conclusion that, or the observation that the proportion of patients with persistent DME decreases with early intensive treatment. Protocol T added one more pearl to it when Protocol T compared bevacizumab, Eylea, and ranibizumab head-to-head, and it was seen that the persistent DME was noted to be having a higher incidence when the treatment is done with bevacizumab as compared to Eylea. And when Eylea and ranibizumab were compared together, the incidence and of the persistent DME was not noted to be statistically significant. However, with progressive continuous injections and intensive treatment with Eylea, the incidence of persistent DME did decrease over week 24. So when we encounter a patient which is not responding to your drug, so what do we do? When we look into the literature, there are studies which favor switching to another anti-VEGF. The logic given is that probably a multimodal action being there, which acts and causes a response to a patient who is a moderate responder or a non-responder. There are studies which favor continuing the same anti-VEGF. If you look into the literature, some studies say that if you keep on injecting with ranibizumab, the effect is seen up to 52 weeks. For that, even with Eylea, the effect is seen up to 104 weeks. Whereas there are studies which favor switching to another agents like steroids. They put forth that look for some OCT biomarkers, and then if at all, if you find an OCT biomarker, which I look for in the second case, then switch over to the steroids. So even the Vivid Vista study, however, when regarding the limited and early responders, this study specifically came to a conclusion that if you continue with anti-VEGF, that is the Eylea, limited or early responders do show an improved benefit after a recurrent DME. So what I basically do is I perform my angiography and see is there any coexisting pathology because of which the patient is not responding to, and I continue with the same anti-VEGF. If there is no ischemia, and then the suboptimal response can be due to tachyphylaxis or resistance, and then I basically go for a switch, and you can consider a switch in those cases. In patients with recurrent DME means those patients who have had a history of recent injections. A history of recent injections, probably like 6 weeks back, the patient, more than 6 weeks back, the patient has had a recurrent DME. There is no anti-VEGF within the eye. In that case, I perform an FA. I note, even if the ischemia is noted, I treat it and I continue with the same anti-VEGF. And even if it is not noted, even though I continue the same anti-VEGF, so I don't go for a switch in recurrent DME cases. So then ponder on the points that what was the possible reasons for the effective switch in the sex. Probably it was a multi-pronged effect of Eylea or a response to tachyphylaxis, or persisting with treatment as seen in some RCTs, or the starting visual acuity was less than 20/32, so the effect of Eylea was better. So the take-home message from this is basic dictum for any patients treating. We are treating for diabetic macular edema is to start early and persist with the treatment. As Dr. Ahmad Al-Kashab very rightly said, that keep on injecting till the patient get dry. There is an, if at all, if we are dealing with a patient which is having a suboptimal response, then it is necessary to find out the reasons for suboptimal response. The possible reasons can be inadequate treatment, coexisting pathology, or tachyphylaxis. Now, there can be, there can be a debate that what do you actually mean by inadequate treatment? But for me, I basically, at least, as I told you, I go for the labeled usage, what has been given by the company. So in cases of persistent DME, it would be good if we ask ourselves that did the patient receive any injection 6 weeks back? Did the patient receive a full course of treatment, or is there a coexisting pathology? If the answers are yes, yes, and no, then it would be a good idea to consider a switch. Thank you for your attention.
Thank you very much, Dr. Turaj. I think it's very nice and excellent presentation. Actually, we are exceeding all the time. So if you can go to the second part of our meeting, then at the end, if we have a time, we can discuss the cases if there is any questions. Dr. Ayman, I think if you can start share your presentation and our discussion today about the controversy in dealing or management of epiretinal membrane.
Good evening, everybody. Thank you, Dr. Muhammad, for the nice invitation. Thanks for Bayer. It's a privilege to be among such an excellent speakers. My talk today will be about case-based discussion, controversies in epiretinal membrane management. Let me start by looking at the most recent staging of the epiretinal membranes. At stage 1, as the foveal depression is preserved, there is a membrane, but the foveal depression is preserved, and all the retinal layers are well defined. Stage 2, we lose this depression. In stage 3, we have a continuous ectopia of the inner foveal layers, as you see here, that cover the whole of the foveal area, but all the retinal layers are well defined. Now, in stage 4, we have complete disorganization and thick ectopia of the inner foveal layers, covering the whole foveal area, and all the retinal layers are disturbed. Now, if we look at this case, this is a case of stage 1 epiretinal membrane. You can see it over here. And this patient has been following this patient since 2019, and this is in 2020, 21, and is still the same. So the majority of epiretinal membranes are stable, and we don't need to do any surgical intervention. We need just to follow them up. Now, surgery is needed in advanced cases where visual acuity is less than 0.4 at presentation, or in cases with progressive loss of vision on follow-up. Intravitreal, let me just say this, intravitreal injections are of no use in treating macular edema due to epimacular membrane. But just let's pay attention here. In diabetic patients, we quite often find some sort of epiretinal fibrosis, stage 1 or 2, and with macular edema. In these cases, particularly, it's very advisable to start with anti-VEGF because, in my experience, most of these cases, they respond to anti-VEGF, even if they have very mild epiretinal membrane. But if the patient is not diabetic, usually, and the cause is due to epimacular membrane or epiretinal membrane, those patients, they don't respond to anti-VEGF. And I've seen a lot of patients that's been injecting, have been injecting them with anti-VEGF with no response at all. Now, what are the factors affecting the visual outcome post-operatively in these cases? Number one, and the most important, is the integrity of retinal layer, especially the outer retina, the photoreceptors. Now, let's look at this case. This is a 70-year-old male patient with visual acuity of 0.6 in the right eye and 1 in the left eye. If we want to stage this, this is stage 2, because there is no ectopia, there is loss of foveal depression. Now, the question is what to do. Shall we wait or shall we go ahead with surgery?
I would go ahead with surgery. If he's symptomatic and complaining, I would go ahead with surgery.
Yeah. I totally agree. This patient, in fact, is symptomatic because he has metamorphopsia. This
Even
is why
Dr. Ayman, if the vision like this 0.6, 0.7, 0.8, you will go for surgery?
This is a very important question. This is what I'm answering. This patient has a progressive loss of vision, number one, and he has metamorphopsia. Because of this progressive loss of vision, the patient's vision was better than this in the last few months. Because he has progressive loss of vision and he has metamorphopsia, I decided to go for surgery. So yes, I did surgery, and you look, the patient is back to 6.6. Unfortunately, not all of your cases are like this. I'm going to show you. I'm not going to show you all my perfect cases, but I'll show you some of the different outcomes. Now, this is a 60-year-old lady, hypertensive, presented with blurred vision, her right eye. This was June 2018. The vision was 0.6. Now, what would you do? There was no metamorphopsia. The vision has been like stable for the last, let me see, 2 visits, 3 months apart. What would you do?
I would follow up.
Inject?
I don't think injection will do in this case, because
this is diabetic or not diabetic patient?
He's not diabetic. This is
not diabetic. Okay.
He's not diabetic. No, he's only hypertensive. He's only this lady. So I waited. She came. This was in June 2018. This was March 2019. The same patient. The vision has dropped to 0.4 now.
Now surgery.
There is some edema. At this stage, I decided to go for surgery. I think we cannot delay things more. So I went for surgery. This was her surgery. I want to show you. There was a significant membrane. There was a significant membrane covering the macular area. In this case, I did not use any dye, although I use it in most of my cases. But I could see the edge of the membrane quite easily, so I decided not to use any dye in these cases. You can see the membrane was a bit thick. Now it's been removed completely. This was in April 2018, and this was in July 2019. What I wanted to say, in the previous 2 cases that I've done, there was a significant improvement of vision. Why? Because if you look at the photoreceptor layer, if you look at
junctions.
Yeah, it is very well preserved. So if you look at this before and after, this is a very important prognostic factor in these cases, and this is why patient they improve. Now, let's look at this patient. This patient is 78-year-old patient, male patient. Hypertensive, ischemic heart disease with vision 0.3. If you look, this is a stage 3 epiretinal membrane. And if you look at the photoreceptor and retinal pigment epithelial layer, it's very well disturbed. So, yes, I will do the surgery for you, but I cannot guarantee the prognosis. I will guarantee removal of the membrane for you, the fibrosis. But what's going to happen after that, I don't know. Now, if you don't do surgery, doctor, what's going to happen? Most probably you are going to worsen more. So let's go and do surgery. So we went and we did surgery, and this was the same patient, hardly 0.4. There was no membrane at all, but you know, the outer retinal layer are a bit disturbed. This is hardly 0.4, but he is stable. Now,
but this is major improvement in vision. Still,
yes, 0.3 to
patient
0.4
would definitely
to 0.4,
feel much better.
For me, for you, yes, but for some patients, it's not a big difference. Definitely, this is a successful surgery for me.
Yes, yeah.
But if you compare this with the previous patients who improved almost to normal vision, there is a difference. Definitely, there is a difference. Now, another thing that we have to look at carefully is the duration or loss of vision in these cases. The more the duration or loss of vision in these cases, the worse is the outcome. I'll show you. Now, this is a 60-year-old female patient. She's a friend too. I've known this patient since we were children. And she came to me and on routine examination and found the patient has stage 2 epiretinal membrane in her right eye. You can see the membrane. She is 6'6", so I decided to wait and follow. The patient disappeared for 2 years. This was the first visit, and this was the
We lost Dr. Ayman.
Yeah, it seems so.
severe membrane.
Okay, Dr. Ayman, we lost you for 1 minute. I think your internet was not, so if you can repeat the last things.
Okay. I'm saying that this is a 60-year-old female patient. I've known this.
She disappeared for 2 years.
2 years, yeah. We reached to that point.
After 26 months, after almost 2 years, she came back with stage 4 epiretinal membrane. Vision is 0.1. Look at this membrane. And if you look at the it's very disturbed, very disturbed. The retinal pigment epithelium and the photoreceptors is very disturbed. This is her surgery. In fact, the membrane was not that thick. You know, I could remove the membrane easily. It was not difficult to remove the membrane, but the problem is removal of the membrane. I put dye, of course. Is that there is macular edema underneath. So you might injure the underlying tissue quite easily while you are removing the membrane, but fortunately we did not. And this was 5 days post-operative. This was 5 days post-operatively. The retina looks much better, but the vision did not improve. The vision was 0.1, and at this stage was still 0.1. Now, ultimately, we ended up with 0.3. I'm going to show you later, but this is the pre-op and this is the post-op colored photo. Now, the presence of, let me say, exudate with chronic leakage. You know, the chronic leakage is a problem. Sometimes if the patient has a membrane and he has chronic leakage, they end up with hard exudates. The visual outcome, the prognosis usually not as good. I'm going to show you. The membrane was not that thick, but look at the exudates in the foveal area. It's quite significant. Those patients who didn't expect visual improvement, as you see in the straightforward cases. This is an unedited peeling. So we could remove all the membrane. Now, if the patient has severe foveal dystopia, when the fibrosis is quite thick and it's pulling the fovea away, usually the prognosis is not that. I'm going to show you this case. This is a 17-year-old female patient, completely healthy, stage 3 epiretinal membrane visual acuity was 0.3. She has severe foveal dystopia. I've done this case probably 7 or 8 years ago, but I'm going to show you. You could see the foveal dystopia, the traction of the fovea downwards, and you could see very thick membrane is going up to the optic disc. I peeled it, and I had to cut it from the optic disc. It was that thick. We did cut the membrane. I removed it. And in fact, I don't do routinely ILM peeling, but in this case, I did ILM peeling just to make sure that I am removing all the fibrosis. And in spite of that, the patient did not improve. 0.3, she ended up, this is in case a patient from Periphery, from Libya. In the next 2 or 3 weeks, the vision improved to 0.3 plus, then the patient was lost for follow-up. I don't know if she had improved more or not. Now, what about macular edema? The persistent macular edema after surgery is an important cause of non-improvement in peripheral membrane surgery, or even sometimes it might lead to worsening of vision after surgery. So, what to do? Let me show you. This is the case that I've shown you with the stage 4 peripheral membrane. The patient she was 0.1 this, after surgery. She was 0.1, then a few weeks later she improved to 0.2. And she stayed, this was, I think, let me look at the, this was the 15th of September. And now this is February 2021, almost 6 months after surgery, and there is no improvement in vision. What to do? What would you do, Ahmad, in these cases? Would you wait more? I waited 6 months. The vision did not improve.
I would consider a steroid implant as an option that can resolve this edema, and it definitely can help. I would not totally, I would not say that it will allow all the edema to go away, but it would control it in a better way.
Dr. Ritoraj, what would you?
Yeah, especially if the patient is diabetic, and if the patient
she's not diabetic. She's only
not diabetic.
No, only hypertensive.
What I have seen in a few of my patients, I have injected a steroid implant, but it doesn't respond that much in terms. It doesn't lead to so much of reduction of central retinal thickness. Neither it has an improvement of vision. However, what I have noted that if there is a subgroup of diabetic patients which are having an epiretinal membrane and which is having this kind of persistent edema, they do respond to steroid implants.
So, in fact, what I did, I totally agree with both of you. I did Ozurdex injection in this case. And this was the result. She was 0.2, and this was 2 months later. She improved to 0.3. There was quite a significant improvement of edema in this case, although there wasn't a significant improvement of vision, but it's improvement of vision. She was 0.3. Now, she came 2 months after that last visit with recurrence of edema. Now, the vision was 0.1. She was 0.3 before. So I decided to do Ozurdex injection, and 1 month later, I followed this with micropulse laser. I treated that area with micropulse laser in addition to Ozurdex injection. The patient improved to 0.3, and there was a significant improvement. Now, this significant improvement has lasted 5 months, not as before 2 months. The patient was better for the last 5 months, and she came back with a recurrent edema. So I gave her the third Ozurdex injection, and the patient, I've seen her 3 days ago. This was the examination a few days ago. She's 0.4 corrected, and the edema has significantly decreased. I'm thinking of do of micropulse laser for this patient after 1 month. So it seems that intravitreal steroids and micropulse laser might have a role in improving persistent macular edema post-operatively, because I think it's beside that the outer retinal layer are a bit disturbed, but there's an element of inflammatory element in these cases, and this is why those patients, they might benefit from steroid. And I think giving the micropulse laser will improve the retinal pigment epithelial layer function. This is why I think we need a lot of studies. We need a lot of controlled studies. We need larger samples to do a perfect judgment on this. But I think doing the micropulse laser might improve the function of retinal pigment epithelium. However, it's worth noticing that in general, any improvement in vision will not be appreciated for several weeks and sometimes even to 1 year after epiretinal membrane surgery. Now, a take-home message is most of the patients with epiretinal membrane are stable and they don't need surgical intervention. We should operate early, and I stress early in cases which need surgery. If the patient needed surgery, don't postpone surgery because patient worsens. OCT is the gold standard for pre-op and post-op evaluation of the outer retina to predict prognosis. Using dyes usually facilitate the procedure. Visual acuity results might be hard to predict, especially in severe and chronic cases. Ozurdex injection and micropulse laser may have a role in management of persistent macular edema after surgery. Thank you.
Thank you very much, Dr. Ayman, for this excellent presentation, as usual. I think we have many questions in our mind and point to discuss. If you will just go a little bit back to Dr. Rituraj before we go to your cases, and then we will have Dr. Ahmad case presentation. So if there is any questions or comment about Dr. Rituraj presentation, Dr. Ahmad, if there is any question, yeah.
Dr. Ayman.
Go ahead, Dr. Ayman.
Go ahead, Dr. Ahmad. Go ahead.
An excellent presentation, Dr. Rituraj. Thanks a lot for sharing these cases with us. I just wanted to emphasize on one point, the ischemia treatment. Up to now, there is no ischemia treatment. Maybe you meant laser, so to close this ischemic area and to decrease the VEGF load on this patient. I definitely agree with you in cases of PDR and severe PDR, severe NPDR with a lot of ischemia. I think PRP would be a good choice. Sometimes we are masking the activity of the diabetic retinopathy by giving the anti-VEGF. So evaluating the new vessels is crucial and very important. Whenever we are examining the patients, we should not be missing out the periphery of the retina because we are treating the diabetic macular edema. And definitely, I cannot emphasize more on this as you showed. Second point is because the first patient, I think he or she came late and there was a lot of hard exudates and there was disturbance of the outer retinal layer in both eyes. That's why I think this is the major cause of this poor vision and poor visual gain. So as you emphasized, treat early and do not allow this hard exudates to accumulate in the central part of the vision is very important. But thanks a lot. It's a great presentation. Thank you very much.
I cannot agree more with you. You have summarized it so well. That's the exact message which I wanted to give. Thank you so much.
Dr. Ayman.
Thank you, Dr. Rituraj. These were really excellent practical cases because this is what we face, in fact, in our daily practice. So thank you. It was an excellent presentation. My comments is number one about ischemia. Now, we see quite often cases with very minimal diabetic changes and still they have cystoid macular edema. And I've shown in one of our presentation with Dr. Muhammad, two of my cases, where you have to look at the periphery of the retina, where there is a significant ischemia in these cases. So do not neglect, talking to our junior colleagues who are listening to us, don't neglect the periphery of the retina in diabetics, especially when you see macular edema with very minimal changes, diabetic changes. Treating this ischemia with PRP and giving anti-VEGF, they give excellent results. This is number one. And sometimes if the patient is not responding to the anti-VEGF, the responsibility is on the peripheral ischemia in the retina. So you have to tackle this. It's important. This is number one. Number two, in non-responding patients, look at the general condition of the patient and the diabetic control. Sometimes if the patient has a poor diabetic control, hemoglobin A1C, high hemoglobin A1C, if they have hypertension that's not controlled, they are smokers, all of the controlling of these factors will help controlling the cystoid macular edema. The third one is the traction. If the patient has traction on the macula, significant traction sometimes, whatever you treat, you give anti-VEGF, the patient is not responding, not because it's not working, it's because of the mechanical traction on the macula. So these are the points that I wanted to highlight for our colleagues to look at if the patient is not responding beside what Dr. Rituraj and Dr. Ahmad Al-Kashab have said. Thank you.
Dr. Ahmad, I mean, I could not agree with you more. I would like to add one more point where, the fashion is to do an angiography and look at the central part for the foveal perfusion. So basically, as you very rightly suggested, that there can be a problem with the periphery. So it highlights the importance of a wide field angiography so as to rule out these ischemic areas which could be a problem.
Absolutely.
Thank you.
Thank you very much. I think there is one point, I think, Dr. Rituraj, one of the message you are talking about the shifting or switching to another anti-VEGF. So I want to ask you when you decide to switch, I mean, if you start, for example, with Eylea as a management, did you switch to another anti-VEGF after Eylea?
What I have done is that I go for, if at all, if I have started the patient on Eylea, I go for the prescribed regimen of 5 injections. If I have done it myself, or if the patient has received it before somewhere else, and if the patient has received it more than 6 weeks, 6 to 8 weeks back, then I treat it as a recurrent case. If it is received 6 to 8 weeks back, and I basically look for the other causes why the patient is not responding to Eylea, and then if there are other causes, just as I mentioned in my first case, I treat them and then restart the same injection. However, if in my hands, if at all, if I've started the patient on 5 injections of Eylea, and if the patient is not responding, I would specifically go for looking for the OCT biomarkers. If at all, the OCT biomarkers are showing that there are some subretinal fluid or high risk reflective spots or chronic inflammation, like presence of a lot of hard exudates, patient pseudophakic. In that case, I go for steroids, or otherwise, as we all of us know that sometimes many patients who are there are certain patients who are not responding to Eylea, because of tachyphylaxis at times, do respond to ranibizumab. So after 5 injection, I do change over them to ranibizumab. Yes, but provided I rule out all other causes.
Thank you very much, Rituraj. Now we can go to Dr. Ayman presentation. If there is any question from others, Dr.
I think
Ahmad.
there is one question from Dr. Ahmad Al-Bar'i. He's asking about, do you inject patient with the 20/20 vision during the loading doses after the second injection?
I saw that question.
The macular edema resolved and visual acuity is 20/20. If I may answer it, and definitely Ahmad would know, yes, I would continue injecting at least for 3 injections because the relapse would definitely be there. So if we'll stop at that point, we will give the patient relapse and then we will start the treatment once again. So continue at least I would say 3 injections, and after this you may extend if the condition is totally stable. You may inject, jump, treat and extend, and you make it 2 months. It is not a rule that you move on 2 weeks. So if everything was stable for 2 successive injections, maybe you can extend even more. But I would not stop at that point.
Ahmad, I think Dr. Ahmad, he's talking about if you start with the patient having less vision, then improve to 1/1, right? This is this question. But suppose you
after
are
1
not
injection.
After 1 injection. What do you think, Dr. Ayman?
I would continue, definitely. I would continue up to 3 injections. Then I'll treat and extend.
Do you think in these cases, if those they are improving very fast after 1 injection, do you think BRN treatment? Even Dr. Ahmad, I know what he said about it. Is there a rule for that, or you will go every one of you here for treat and extend?
let me tell you something. And even if the patient has improved from the first injection, I would continue. Those patients, they need probably like 8 or 9 injections per year. Now, if you start with full dosing of anti-VEGF, and if you treat those patients promptly, as Dr. Ahmad said, the percentage of relapse in these cases is very much less. And definitely, as VIVID and VISTA and other studies have shown, if you treat those patients aggressively, the visual gain at the end of the year is much better than treating them just on and off. So definitely, I would continue.
Dr. Ayman, how you will convince a patient that his vision success to continue treatment?
In fact, I sit down and I talk to my patients. This is what I do in my clinic. I give my patients enough time. I discuss their cases. I discuss the pros and cons of the treatment, and I tell them what to do. My patients, thanks God, they trust me. If they trust you, they will follow you, because they know that you want the best for them. You are not, looking for the financial gain of this case. You are looking for the benefit of the patient. So if you explain scientifically what's going on to the patient, if you tell them some scientific results or about the literature, about the data, they are convinced most of the time.
I agree totally with you. Just one point, Dr. Muhammad. For such cases, when you explain to the patient, Dr. Ayman just clearly mentioned trust, and this is very important. But the patient should initially understand that this is a disease. We should not be stopping the treatment in the middle of the treatment. For example, if you have an antibiotic for a fever, and after the first dose of antibiotic, the fever is gone, would you stop the treatment and you would lose the effect of this antibiotic, or you will start again with another antibiotic regimen because the fever will relapse? So
I'm talking about the patient, Dr. Ahmad, not the doctor.
Yes, that's
I know the doctor.
Doctor,
I know.
I explain to the patient the same way.
Okay.
I explain to the patient that this is a dosage that you need to continue, or else we will start again. And we should not be going into the yo-yo effect. The retina is dry and then relapsing again and then starting again. So this yo-yo effect is affecting the integrity of the retina and affecting the visual acuity on the long term. The photoreceptors will not handle this well.
Thank you, Dr. Ahmad, for that. We can go to for our topic about the epiretinal membrane. If there is any question to Dr. Ayman from Dr. Ahmad or Dr. Rituraj, we have some questions from our colleagues here and participants. I can go through of them first, then maybe we can have our speaker. Okay, there is Dr. Ayman. I think he said, what do you think the cause of such epiretinal membrane in a healthy 17-year-old patient? I think one of your case, you mentioned that he's, okay.
In general, the idea about the cause or the pathogenesis of epiretinal membrane is the faulty PVD, where you leave after faulty PVD, some hyalucytes are remaining on the retinal surface, which cause migration of monocytes and fibroblasts, and then the whole issue of fibrosis will start. Cellophane maculopathy then will contract, causing macular pucker, or what we say an epiretinal membrane. This is in adulthood. Now, in the pediatric age group, it's a dilemma. Nobody knows what is the exact cause. Is there an inflammatory initiation on the surface of the retina causing this? I want to add, in this case, there wasn't a PVD. The vitreous was attached to the retina. This was the dilemma. There wasn't a PVD as we see in most of the cases of epiretinal membrane in this case. So in the pediatric age group, it was a dilemma. I think it might some sort of inflammation might be involved in this case, but I don't know exactly the answer.
Ahmad, if you have any more comments or Raj?
I agree with Dr. Ayman, definitely for the idiopathic, but I need to emphasize on the importance of examining the periphery of the retina, because as we know, there is if there is any tear in the periphery of the retina or any previous laser or cryo, this would initiate development of epiretinal membrane. So in such case, it is not anymore an idiopathic, there is a cause. So we need to examine the periphery of the retina very thoroughly in such cases. For young or pediatric age group, I agree totally with Dr. Ayman. It is an inflammatory reason, or it can be secondary to any trauma, whether the patient remember it or not, and or there is any lesion as well in the periphery of the retina that we should be examining as well. But it is in such age group, it is not related to PV.
Totally agree. In our case, I put down that the patient was completely healthy. There wasn't any, she denied any history of trauma. The retinal examination, the periphery was quite, I in fact thought that she has an intermediate uveitis at the beginning, you know. This is one of the most common causes of epiretinal membrane is the intermediate uveitis in such an age group, but you know, looking at the retinal periphery was completely normal. She was completely healthy. She gave no history of trauma or any previous uveitis, and this was just only on routine examination, visual acuity examination. She discovered that she cannot see well with her right eye. So but I think still the inflammatory causes or trauma are the most common causes of epiretinal membrane in pediatric age group, definitely. But in that particular case, I don't know the answer.
Is there a rule? Sorry, yeah, Dr. Raj, go ahead.
If I may come here, regarding the excellent point which Dr. Ahmad had made to check the periphery, one more point which I would like to add as well, that if at all, if there is a young patient, there at times can be multi-layered epiretinal membrane as well. While handling, if you're doing a surgery at that time, if you remove one layer, you'll be surprised to find another second layer of epiretinal membrane being there. So staining is a good idea, and go up to and peel the ILM so as to remove the whole scaffold, because at times recurrences of membranes are also known.
I cannot agree more with you, Dr. Raj. Absolutely. I totally agree with you. Yeah. Definitely. And what you said about the multiple layers is a fact, because you can see cleavage or schisis in the posterior vitreous phase in these cases, where you might miss one of these. This is why after removal of this membrane, I peel the ILM, just to make sure that I'm removing all of any inflammatory initiative in the retina. But I don't usually remove the ILM in my cases, as you have seen while I'm peeling the membranes.
We can go to the next question. Is ILM peeling or the use of the dye involved in the persistence of post-operative macular edema? Dr. Ayman?
Well, definitely the dye is toxic to the retina. Whenever you can manage your things without using the dye, I prefer not to use the dye. In fact, I started my peeling of ILM for quite some time in macular hole without using the dye. But fortunately, nowadays we have some dyes with very much less toxic effect on the retina, like the brilliant blue, where the toxic effect on the retina is very much less. I cannot rule out the toxic effect on the retina from the dye itself, and even from the lighting if the surgery is prolonged. But definitely there are more important causes that's been involved in the persistence of macular edema, like the inflammatory process from the membrane itself or from the surgery, and the disruption of the outer retinal layer, especially the retinal pigment epithelium.
Okay. The other question, this is directed to you, Dr. Ayman, from one of our participants. He said, could you please comment on the development of macular holes post-epiretinal membrane peeling, especially in the presence of cystoid macular edema, and how to avoid it intraoperatively?
Yeah, there's a whole spectrum of vitreoretinal interface problems. The epiretinal membrane is one. Now we have the lamellar hole, we have the full macular hole, and we have the VMT, the vitreomacular traction. All they go under the same spectrum, which is the vitreomacular dysfunction syndrome. Now, in case of lamellar hole, the pathology is different. We have two types of lamellar hole. We have the lamellar hole caused by the membrane over the macular area, and we have the degenerative lamellar macular hole, as we see in diabetic patients. Now, the full thickness macular hole is different, has a different pathogenesis due to the traction on the fovea itself, the tangential traction, and the perpendicular traction on the foveal area, leading to different stages of macular hole, full thickness macular hole, from stage 1, stage 2, AUB, stage 3, which is an attached attached posterior vitreous surface, and the stage 4, where the full thickness macular hole with the PVD. So it's the same spectrum, but with different pathogenic or different pathogenesis in every case.
How to avoid?
How to avoid? Sometimes it's very difficult to avoid the formation of lamellar hole or full thickness macular hole in these cases. Now, if the patient develop a macular hole, full thickness macular hole, the incidence of development of the same problem in the second eye over 5 years is between 15 to 20%. So the only thing is just to follow up these patients, and if the patient develop this problem, is to operate early, because as we all know, if you operate early on full thickness macular hole or on lamellar macular hole, the visual prognosis is far much better. I've given, if you remember, Dr. Ahmad,
yes,
about lamellar macular hole,
yes,
and the prognostic factors. If you need to hear this lecture again, I'm ready to give it. But the only thing, you cannot prevent the development of these problems in the eye. There is no preventive measure.
Dr. Ahmad, I think you want to comment about this point.
Yeah, I want to comment first about the excellent presentation of Dr. Ayman. He covered the epiretinal membrane spectrum beautifully, as usual, and the cases are amazing. But according to this point, I think if there is cystoid macular edema and you are going to remove of the epiretinal membrane, you need to understand the situation beforehand, and you tackle the membrane in a fashion not to cause de-roofing of the cystoid or the large cyst, so that not to develop the macular hole, despite that this sometimes in uneventful, or it can happen even with all the precautions. But you try not to peel the epiretinal membrane over the fovea, over the cyst. You try to make it centripetal and remove it all around and keep a cushion on the cyst. I usually do ILM peel combined with each and every epiretinal membrane peeling. But in such cases, I would definitely, if there is cystoid macular edema, I would avoid to peel over the fovea. I would make ILM peel with foveal sparing to maintain and to preserve this cyst from rupture and from causing any macular hole, if this is an answer for the question.
I understood the question a different way. I understood the question is how would you prevent the development of idiopathic macular hole or idiopathic lamellar hole? There is nothing to do to definitely prevent this. But
Yes.
if, as Dr. Ahmad said, if you are operating on an epiretinal membrane, as I've shown one of these cases where there is a significant macular edema, you have to be careful in peeling this membrane. Now, you can do foveal sparing of this peeling in some cases if you have a very thin cyst overlying the fovea. Yes, you can do this. But if, let's say, you are peeling the membrane and the macular hole happened, what would you do? I would treat it as if it is a case of macular hole surgery. I would peel the ILM, then I will finish the case by gas fluid exchange, injecting C2 F6 or C3 F8 gas and face down position for 1 week.
Thank you very much. I think we can have the other question, but as we are running behind the time, so if we can have a very short, if you don't mind, I'm sorry for that. But there is one question, direct question, Dr. Ayman, to you. Do you do phaco, pars plana vitrectomy, or only pars plana vitrectomy when you are dealing with epiretinal membrane?
Well, most of our patients are elderly patients. Let's say they are more than 50, 55 years of age. There is some element of cataract. I would go ahead and do phacosurgery. But if the lens is quite clear, no, I would not. I just remove my membrane and go out.
I think there is any.
It's not like the macular surgery. There's no gas involved to increase the the incidence of cataract after surgery.
Okay, Dr. Ahmad and Dr. Raj, different opinion or same?
The thing is, no, I had a different question actually. I was thinking about different.
Can we get first of that one, then we can go back to your question. If you have any comment about this one, no. Dr. Ahmad, Dr. Raj, about the same question, no? The same, okay.
I would go for phaco combined phaco-vitrectomy in most of the cases if old patient above 45 years of age.
Even if the clear lens?
Yes, because if there is any error, maybe I would even get this error out of the scope, for example, myope or hypermetrope. But if the lens is totally clear, and I would always explain to the patient the pros and cons of each procedure. But if you combine it, it's one go. You remove it and you remove the cataract and it will not relapse again. So why not? If a young patient, this is a totally different story. So I would not go for clear lens extraction. But above 45, yes, still I would go.
Let me make it short. In most of our cases, we do combined surgery. In most of our cases, just put it.
Okay.
Not all, in most of our cases.
Okay. Other question is residual or persistent macular residual or persistent macular edema post-epiretinal membrane milling, trial of topical non-steroidal anti-inflammatory for at least 3 months is worth to try, especially in case of Ozurdex limitation or contraindication. This is a comment. What do you think about that, Dr. Ayman?
I think it's not a bad idea to use it. I've used it quite a lot. But the response
is there any benefit?
No, there wasn't that great benefit from using non-steroidal anti-inflammatory drops like what you see in cases of post-cataract cystoid macular edema, or in cases of macular edema due to retinitis pigmentosa, where you might have some benefit. But in these cases, no. But it's not wrong to use it.
Are using it routinely. I do not try it. I am using it routinely for all post-op cases. So it is already there. If there is persistent edema, it will not make any difference. So if there was some edema and it improved with the use of non-steroidal and steroidal drops, it would. If not, it is persistent, and that's the term that we agreed upon, persistent edema. So it did not respond on all of these, but definitely it is a part of the routine post-op medications.
No. We are not talking about post-op medication. If you are going to use it, yeah, I know it is, but I am saying, are you meant or you mean to use it as a method of treatment instead of steroid? So if there is an indication to give steroid like Ozurdex, is it a replacement for that? It can work. Like this is the aim.
I agree with Dr. Ayman in this answer. No.
Okay. So
So
do you do okay? Yeah, Rituraj.
If I may come here, many times this thickness, what the post-vitrectomy macular thickness is because of dissociated retinal nerve fiber layer. Because if ILM is with peeled, the nerve fiber layer just becomes a bit swollen and thickened up. It's not more of an extracellular edema over there. So when the NSAIDs, like for Nevenac, if it is used for 3 months, it actually doesn't cause any major benefit. So the same thing goes for intravitreal Ozurdex as well. If at all that thickness what you are seeing is especially because of the dissociated retinal nerve fiber layer, in that case even Ozurdex will not work that much. If there is a component of an edema because of an underlying inflammation, then and then only the Ozurdex would work.
Okay, thank you, Dr. Rituraj. Okay, the question, do you adopt a modified treat and extend protocol for DME? I think Dr. Ahmad or Dr. Rituraj, one of you.
It is a treat and extend. Modified means I would examine the patient in between. So sometimes I do this. It is not a typical treat and extend. So the patient would come anyway after 6 weeks and he gets an injection, after 8 weeks and gets an injection. Sometimes he comes even earlier and making an OCT just to make sure that this extension did not affect the edema. If this is the meaning of modified treat and extend, I'm doing the same, but let's keep the label as it is, treat and extend. Yeah.
Okay, I think we have the last, not the last, we have this as a question, then we are having another 2 chat. This is a comment. There is a comment from Dr. Mohit. He says, screening of periphery for old silent parasplenitis, post-ibretinal membrane removal, subtle intraocular inflammation and persistent macular edema. These cases do well with early Ozurdex. Is there any comment about this one?
Yes, as I said, I totally agree with Dr. Bahit. One of the most common causes of macular edema and sometimes ibretinal membrane over the macular area is the intermediate uveitis. This is why it's very important to look at the periphery of the retina in these cases. I totally agree. Intravitreal steroid in persistent cases or in resistant cases might give very good results. Yes.
Okay. We will have 1 minute just like an advertisement, then we will continue. If you allow me, can you management event play the video, please?
We are the pioneers, the discoverers of the unknown, exploring new innovations that go beyond our world. Pushing what we know to new heights. Mining the landscapes of cell and gene therapy to unearth better treatments and cures. Expanding the frontiers of care with artificial intelligence beyond what the human eye can see. Traveling further than just medicine with digital solutions like home monitoring to transform the treatment of retinal diseases. We are on new journeys of collaboration help more patients than ever see a better life.
Okay, thank you very much, management event and Bayer, for this nice video. Okay, we have one question or comment. I think is a question. This one is LM peeling or the use of the dye involved in the persistent or post-operative. I think we answered already this one. The same question we have answered.
Let me answer about the ILM peeling, or just more clearly.
Okay.
The ILM recently, the ILM peeling in peeling of epithelial membrane is not indicated. Although studies have shown that the anatomical outcome is better when you peel the ILM, but the functional outcome is the same. So because most of the time when you are peeling the epithelial membrane, most of the ILM is peeled with it. This is what has been shown by analyzing and testing the membrane itself when you do histopathology on these. Most of these cases, the ILM has been peeled with the epithelial membrane. So it's not indicated because there is no functional outcome difference between the peeled or unpeeled cases.
Okay.
I would differ because there is a big debate about whether ILM would make a difference with the ILM, with the epiretinal membrane. Definitely, very respectfully, I would differ with Dr. Ayman. I feel that peeling the ILM in such cases of epiretinal membrane would give a better chance for the patient, both anatomically and functionally, to have better vision and better morphology of the retina, especially in very significant epiretinal membrane, because you need to remove the scaffold of this epiretinal membrane, the existing one, and preventing it from recurring once again. So the only way to make sure that you remove the whole epiretinal membrane is to remove the ILM, and the foot pedals of this epiretinal membrane should be removed as well. And sometimes you will be astonished that you thought that you removed the ILM, and if you stain it again, you'll find that there is still the ILM is intact and you did not remove it. So I would respectfully differ with Dr. Ayman at this point.
Well, the idea is removal of ILM is very, is a very interesting idea. This is why when I started doing my surgery, I used to remove the ILM, and I've shown you that I did in one of these cases. But I don't. Why I don't? Because I just stress all the recent studies that has been done on the cases of ILM peeling with epithelial membrane removal did not show any functional benefit over the cases that has not peeled. But definitely they have shown that the anatomical and morphological outcome is better, but not the functional. This is why. This is number one. Number two, peeling the ILM is you are doing more trauma to the retina. You don't want to increase the inflammatory process, because the problem is with the persistent macular edema in these cases, and you don't want to. This was my point of view, or what's been agreed upon, that in these cases recently we don't peel the ILM.
Okay, before we continue,
my question was.
Yeah, Doctor, yeah. Can I give only this announcement 1 minute? 1 minute. Just give me 1 second.
Yeah, sure.
Management, if you can, please put the link for the certificate of attendance in the chat. And I want to say for all participants, they can get the certificate by click on the link that will be now download on the chat. Okay, sorry, Dr. Raj. Yes, go ahead.
Yeah. So my question was for Dr. Ayman as well as Dr. Ahmad. In your experience, what do you find? The post-vitrectomy macular thickness or post-vitrectomy macular edema is more when you peel the ILM or when you retain the ILM in vitrectomy cases for ERM?
I usually do ILM peel, and yeah, the rate of edema is less. I would not say none, but it is less. There is some cases of still persistent edema, and that's why in such cases I inject Ozurdex. But they are, I would say, not more than 10%.
Dr. Ayman?
Dr. Ayman, because Dr. Ayman does both of it. I mean, in few cases he did some ILM peeling as well, and in few cases he doesn't do.
Dr. Ayman, can you unmute? Okay.
Yes, now because I lost the connection for quite a few seconds.
Okay. So Dr. Ayman, Dr. Turaj was asking if you can repeat the question. He was asking after vitrectomy, if you do unpeeling or not, ILM peeling.
Yeah.
Did you find the edema it is there more, or when you don't? When you do in
fact, in the last 5 years, I started not to peel the ILM. So I did not look at my cases that has been operated upon, because all of them.
I think we lost. Okay. Dr. Ayman again. Okay. I think only there is one question before we came to the end of this session. Ahmad and Dr. Raj, till Dr. Ayman came back to us. Ahmad and Dr. Raj, in case of there is an epiretinal membrane, let's say grade 1 or grade 2, or in classification, in case of diabetic macular edema, not in case, non-diabetic. Is there a rule for injection or not? Or when to inject and when or not to inject?
For me, if it is a diabetic macular edema, it is absolutely different pathology. Here, the reason why the edema is coming is more of a vascular cause in a diabetic macular edema as compared to the tractional cause seen in an epiretinal membrane. So if there is a tractional component being in play, there would be some amount of loss of foveal depression, or there should be some amount of traction which should be seen on OCT, so as to label it that it has both of its component, whether it has a vascular component plus a tractional component. So if it in such situation, the vascular, I basically go for treating with injections. These are the cases where there is both of these components being there, where vascular and tractional. I go for giving injections, and then I evaluate the patient later on.
Ahmad?
I agree with Rituraj. I think we should differentiate between tractional macular edema and macular edema per se. So if there is some element of epiretinal membrane and there is significant edema, I would give the patient the treatment of choice of anti-VEGF, but just explaining to the patient that there is some element of traction that we need to keep an eye on it and follow it up. If it persists and if the main cause of the edema is a tractional element, that's the time that we will intervene and do vitrectomy. If the main element of the edema is inflammatory or vascular, the injection would give a very good result, and we may not need to do any further intervention as PPV also.
How long you will wait? How long you will wait for injection? I mean, did you go for 3 injection minimum, or when? How you will decide this one?
I would evaluate every injection, because this is different. This is not just an edema. This is an edema with traction. So I would evaluate after each and every injection. If things are improving, that's the time we'll continue. If things did not improve or the traction is increasing, that's the time we will switch to vitrectomy.
Surgical. Okay, yeah. Ahmad, what do you mean
probably,
by the responding? Okay.
Yeah, most probably these kind of membranes are not the idiopathic membranes. They are there would be some amount of fibrovascular component, and further on there is always a risk that the membrane can contract, and we might end up having some kind of TRD somewhere because of multiple injections. So I would specifically agree with Dr. Ahmad that these patients needs to be monitored very closely after every injection, so as to make sure that you are not causing specifically a TRD somewhere because of the repeated injection.
Yeah, but I mean, in case of grade 1, Ahmad or Turaj, and you give injection, what do you mean by evaluating after the first injection? When you will say there is an improvement or not? What do you mean by
this is a totally different grading. It is not this grading, as Dr. Ayman mentioned.
No, I know, Ahmad. I am trying just to say it if it is similar to that.
Yes, I agree with you. I understand, but I mean, if there is vitreomacular traction.
No, I'm not talking about vitreomacular traction. I'm saying there is sometimes you are treating a patient with diabetic macular edema and you find a very small epiretinal membrane covering that area. Similar what we are seeing in idiopathic. Sometimes you will find that one.
Yeah, definitely. I agree with you.
Sometimes you are giving an injection, the first injection, and you want to evaluate. How do you evaluate? What do you mean by the respond and or to change to surgery? This is what I want everyone to hear from us on to learn that point.
Thanks a lot. So if the edema, it did not decrease or improve, on the contrary, it started to increase because there is a tangential traction of this epiretinal membrane, that's the time I would definitely switch to vitrectomy because the element of traction is the main element of this edema. And sometimes by evaluating the condition from the start, you can see that this membrane is the main cause of this edema. That's the time I would switch the patient directly to vitrectomy. This is a tractional diabetic macular edema or tractional on the central part of the fovea or the macula. But if it started the edema to improve or at least to stabilize, I may continue on the injection.
I think this is what we need to hear about.
We lost the current for quite a few seconds.
Yes, so. We know, Dr. Ayman. We was talking about if there is an epiretinal membrane associated with diabetic macular edema, how to deal with that, and how to inject and when to switch to surgical intervention. If you have any comment about this one, you can already talk with Dr.
I didn't hear Dr. Ahmad, but I would start by injecting definitely, and until I see if the patient is responding, as I said, but probably this is due to macular edema. But if the patient is not responding and we exclude the other things of non-response like peripheral ischemia or central ischemia or poor control, I would go ahead for surgery.
I think we are talking the same. That's what Ahmad mentioned and Dr. Turaj. I think at the end, I would like to thank you all. Thank you, Dr. Ayman, Dr. Turaj, Dr. Ahmad, for this very nice and very excellent discussions and learning from all of you. We wish to see you, inshallah, in the next meeting. Just for our attendees, just not to miss to take, please, their certificate. Just go to the link and get your certificate of attendance. Regarding our certificate of for conference, what that done in September, it will be started from the next sending our CME accreditation, which will be 19.5 for those they are attending, and it will be sent, inshallah, from next week. I hope that everyone enjoy with us today, and we'd like to thank you all, and thanks for the Bayer for sponsoring this meeting, and we hope to see you, inshallah, next week. We will have another session of Retina also discussions. Thank you and good night, Dr. Ahmad, Dr. Ayman.
Thank you.
Thanks a lot, Dr. Muhammad. Thank you. Excellent
as
usual, Dr. Ayman. I learned a lot.
It was a pleasure and privilege
to
speak with Dr. Ayman, Dr. Ahmad, and Dr. Amri. It was a pleasure and privilege to speak with you.
Thank you very much, Dr. Turaj. Pleasure to be with us. Thank you. Thank you, Dr. Ayman. Inshallah, we'll see you, inshallah, after a while. Dr. Ahmad, thanks a lot. Thank you and good night. Assalamu alaikum.
Good night. Wa alaikum assalam.
Bye-bye.
Thank you.